Hello everyone, welcome back to Hot Seats. I'm Omid Moghaddas joining you from Tehran, and once again I'm so grateful to have the chance to be with you all from everywhere in the world from this educational platform. And I have to say, I say it all the time, I'm very honored that so many great speakers, and I'm so fortunate to call them friends, have accepted the invitation and are joining us in this series of webinars in the year of 2020, the pandemic year, that we don't have the chance to join each other in face-to-face meetings. So I think it's a good opportunity for increasing the level of learning and increasing our knowledge, for having a better practice in our profession. And today I have a super talented surgeon as a friend that accepted my invitation. I'm pretty sure so many of you are familiar with his works, and I was telling you before I start to record the session that really the way that he shows the cases, I mean, definitely before I say anything, go on his Instagram page and check his beautiful cases, also on Facebook, because the way that he presents cases, it's like you're seeing some paintings. The surgery is so clean, the steps are so exact and precise. So I'm super excited for his presentation. I'm pretty sure you all will enjoy it, every second of it. So my dear friend from Germany, Jochen Tunkel, is here with me. Hello, my friend, and welcome to Hot Seat. So happy to have you with us.
I mean, I'm very fine for inviting me, and yeah, thank you. Thank you for inviting me, and I think we are having a great hour now.
Sure, absolutely, it will be like that. And the topic actually that Jochen going to present for us is, I think, a very new and hot topic in this field, but also it can be very challenging. As you all know, during the past sessions, we talked about Hui technique, we talked about a split bone technique with autogenous bone and the real bone builders and everything, and so many great guests that we have. But today we will talk about a different aspect in this technique, which Jochen gonna cover for us, and it's about allogenic bone plates, because it may be the question of, for some people, that maybe that's a question that, is it possible to use allogenic bone plates instead of autogenous bone and reduce the time of surgery instead of going and harvest the bone from some area? Some people think that it's hard for them, it's difficult for them. So I think it's so many things to learn from this presentation. And the topic, as I said, is allogenic bone plates, split bone technique 2.0. So before we start, I would like to have a short CV of Jochen for all of you, and then we will go to the presentation, and at the end, we will have a great discussion on the topic. Dr. Jochen Tunkel is a German postgraduate degree in periodontology, also German postgraduate degree in oral surgery, Master of Oral Medicine in implantology, and a specialist of the German Society of Periodontology. Also, in his history of education, he was the visiting assistant professor at the Department of Perio University Clinic Münster in Germany. Also previously was chairman of the section Surgical Periodontology of the German Society of Oral Surgery, founding of the online social media learning platform Regenerative Bioversity, and also he is an ITL speaker and ITL fellow, and so much more. So my friend, we are ready for your beautiful presentation, and really looking forward for the discussion, and the platform is all yours.
Thank you very much. I'm going to start the presentation now.
Sure.
Allogenic bone plates, quite a new thing. It's not that old. Allogenic bone is not a new thing, but before we start with allogenic bone plates, I'm trying to show you a little summarize of how I got there and why I'm using these plates now. And of course, we want to see the differences between autogenous bone plates So we're going to make a little journey through augmentation procedures at the beginning, and that you understand later on why I use this technique and how we use these techniques. First of all, the allogenic bone plate is not the only way to augment, but why do we have to augment the bone? This is in my cases, and as you already mentioned, and as you already know, I'm a periodontist, and so I very often have patients, after losing their teeth, they have severe bone defects. And the point is not to build up the bone, to insert 14 millimeter implants or 12 millimeter implants. We all know that we don't have to use that long implants. But the point is to insert the implants in the right vertical and horizontal position. And if you see the severe defects that will be, especially in the maxilla, that will be very difficult to insert the implant in the correct vertical position. And that's what we need bone augmentation for. Not for the length, not for the diameter, but for positioning of the implants. We have several methods of bone augmentation. We have GBR with resorbable membranes, with non-resorbable membranes, with bone fillers, with autogenous. We have the sinus floor elevation, which I leave out completely in this session because it's some other way of augmentation. And we have bone blocks, autologous bone blocks. We have allogenic bone plate. And we have several other methods. I don't claim that I know all methods that are possible for bone augmentation. These are just the methods I have used and still am using in my office. And that's what I'm going to talk about. Probably the most commonly used method for bone augmentation is the GBR procedure, especially with resorbable membranes. And it's not a bad process if you use it in the right indications. For example, in this case, we have missing anterior teeth, and after opening that, we have enough bone to insert the implants. We don't have to do an augmentation first, but we don't have enough bone just to leave it like that. And so I made a GBR using a collagen membrane, DBBM particles, and the result is quite nice. And what you will always see, and I always show you the complete cases, you always see the second stage surgery in my case, because I very often do some soft tissue management during second stage surgery. And in this case, it's where we use a connective tissue graft combined with a free gingival graft that was grafted over to use between the implants. And after 5 months, you see the provisional restoration, and after 2 years, you see the final restoration. Very interesting here, besides of the bone augmentation, is that the maturation of the soft tissues between 5 months and 2 years, and you see how much time the tissues need really to heal and to have the final result. This is a very nice method, and we use it quite often in our office. But of course, this is not the only method we can use. We have the method of GBR is not used in very cases with severe defects. This is an old case of mine, and I have to say it's a perfect case to show many things that went wrong in this case, and I did wrong in this case, beginning with the incision techniques that are completely wrong. So don't look at that, just see the result. I did the GBR, and you see the complete buccal bone is missing and a part of the palatal wall is missing. And after 6 months, I reopened the area, and you see that it's not really healed. And I asked myself from time to time why I put the implant there. I put the periodontal probe just to show that it's not really hard tissue. There's a mixture of soft tissue and DBBM particles, and this is not a good healing. And I think today I would just completely remove the tissue and start again. And this is what I don't want to do. I don't want to start again. Of course, we all don't want to have complications. But GBR procedures, there are other ways to use them. And for example, we could use the EPTFE membranes. This is a Gore-Tex membrane, which is no longer available on the market, but a very nice membrane. You could have very nice results. If you look at the case here, we have a slim crest area in the first quadrant. I used DBBM particles and titanium reinforced EPTFE membrane. And everyone knows, whoever used this membrane, if it heals uneventful, you have a perfect result. Really, it's really fun to insert the implants. This is, I think, 5 months later. It's really a good thing. You have vital bone, you have good nutrition of the bone. You can insert the implants, and it's really a good way of augmentation. Again, you see in the last row, the soft tissue procedure at the stage 30. Here is an apical reposition flap to regain keratinized mucosa and to have a stable mucosa that the patient can clean the implants, and we have a longer implant life and less complications later on. The problem of the ePTFE or PTFE membranes is that the complication rate is not that low. This is one of my cases where I used another membrane of another company. I have to say I had more complications with this membrane after the Gore-Tex was no longer available. I put the implants, I put the membrane and autologous bone under the membrane, beneath the membrane. And after 2 to 3 weeks, I had a little exposure of the membrane. And as I learned during my perio education is that exposure of an ePTFE membranes means you lose completely the bone. And that's a good thing. It's not really true. You can lose the complete bone, but if you do the right things, you might not lose all the bone. Nevertheless, it takes a lot of chair time now to treat the patient. You have to be see him every week. You have to do, I put some chlorhexidine on the side of the exposure of the membrane. He has to rinse with chlorhexidine. And if you get an infection, the membrane, you have to remove it quite early. I try to keep the membrane for about 6 to 7 weeks, 8 weeks, and then I remove it. And in this case, this worked quite well. We have quite a good result here. But I have some cases where it completely failed after the membrane was exposed. So, how many complications do we have after vertical bone augmentation? Especially, we're talking today more about vertical bone augmentation. And this was a nice study by Rocchietta comparing the complications after vertical bone augmentation. For a long time, I always cited this study because it wasn't that strict with the inclusion criteria of the studies they used, and so they got quite good results, in my opinion. They used prospective and retrospective study as well in this analysis. And as you can see, the distraction osteogenesis was far beyond good with 14% to 75%. That's probably the reason why it's no longer used so broadly. But the GVR was much higher with 9 to 45.5% complication rate compared to the onlay bone graft, which is full bone blocks, yeah, not the shell technique or split bone technique. But we have to say there was a nice, very good systematic review last year, Istan Urban, and this results, to me at least, were quite strange, because in this review, the guided bone regeneration had less complication rates than the bones. And what was very nice in this review, this was the first time that the shell technique, the split bone technique, was analyzed separately from full bone blocks. And as you can see, we have a 12.1% complication rate during guided bone regeneration and 17.1% by split bone and 23.9% by full. Nevertheless, most persons I asked, and I myself have to say the same thing, who do both things, the membranes, especially the ePTFE membranes and the bone blocks and the shell technique, most people say they have less complications with the bone blocks. But I have to be very careful with my opinion, because I learned with Professor Curry in his clinic, and I learned the bone blocks really step by step, the split bone technique. And of course, I think I'm better with the split bone technique than with the ePTFE membranes, therefore, and of course my complications rate might be lower for that reason. But we have to keep that in mind, that the split bone technique is not that much different from the guided bone regeneration in complication rate. I use the microsaw when I harvest the bone for the autogenous bone blocks, as probably most dentists who learned with Professor Curry will use. Of course, you can use the piezo surgery device as well to gain the blocks. And I think it's quite known it's quite famous already, the technique. It's a very nice technique Professor Khoury invented in this area. You get a retromolar block. I only harvest retromolar blocks. I don't harvest in the chin area anymore because the complication rate in that area is in the retromolar area. And we have a very, very nice possibility to gain really big blocks. And as you can see in the picture on the right, that was the biggest block we ever harvested in our clinic, in Professor Khoury's clinic. It was about 54 millimeters in length and 19 millimeters in the greatest height. So this was really a big block. And so big blocks, and then we divide this block into small plates, and these small plates are used to build the crest in the first area. Let's have a look at this case. It's a patient with a quite big defect in the area of the second quadrant. I harvested a block in the retromolar area on the left side. Then I splitted the plates, and I always, that's probably a bit different from other people you see using the split bone technique. I always put a buccal and an oral plate. I never put a vertical plate or an occlusal plate on top, because I always use a crestal incision, and I don't want to have the occlusal plate beneath the crestal incision. So I first fixed the buccal plate with 2 screws, later on the oral plate with 2 screws, and by thinning the block with the safe scraper, you gain a lot of autogenous bone chips, and you put the bone chips in between. We take a 4-month healing time, and after 4 months we open up, and you can perfectly see that the big advantage of the shell technique is that we don't lose very much of the augmented bone. The resorption rates are quite low. From 2 studies which I performed with my close friend Luca Di Stavola, we know that we lose about 5% in horizontal augmentation cases and about 9% in vertical augmentation cases. That sounds pretty much, 9%, but you have to see if you augment 6 millimeter, which is quite a big augmentation in a vertical case, you lose about 1 millimeter of that. And so it's very, very stable results. So it's no problem now to insert the implants. Nice bone, very good bone to insert the implants. And we let this heal for another 4 months. And after 4 months, again, soft tissue management during second stage surgery to regain keratinized mucosa. And this is the case 8 years after the insertion of the implants, after the prosto was done. And you see that we have very, very stable bone conditions here. And this is very a nice case. So the shell technique is not only very predictable, you can use it for very big augmentations. Again, the systematic review by Istvan Urban, and as you can see, the medium augmentation value in the shell technique is higher than the medium augmentation of all other techniques. It is only beaten by the distraction osteogenesis, which could be shown that we have a high complication rate there. And therefore, we have a very, very nice technique. We can do big augmentation with low complication rates. And that's probably the good thing about the shell technique. But nevertheless, we have complications. And that's, of course, something we don't talk very often about. But I show you 3 of my cases where I had complications after using the shell technique. The first one in the upper line is a patient I used with split bone technique, autogenous bone. And after 3 years, the patient showed up in my office again, was sent by the referring dentist and said, have a look, there's something wrong. And I lost some bone in the crestal area. And you see, after second stage surgery, the X-ray, the implants were perfectly integrated at that time point. So we lost in the first 3 years some of our augmented bone again. And the second case in the middle line is a case where I did a lateral augmentation procedure, and we have these cases, not very often, but we have cases where we have a higher resorption rates of the augmented bone, and then we have to do something, of course, again. And the third case is we did a lateral augmentation here, and you see we have a good integration after opening up again. And this was a case where my dental hygienist showed up in my room. You know, if the dental hygienist shows up in your room and you did not have an appointment with her, you know there's something wrong with one of your patients. It's always a bad message. And she said, oh, can you have a look at this patient? He has some pus coming out from his pocket. I took the picture where you can see the pus coming out, and I took the periodontal probe, and all probably know what happens if you go down there. It will make click, click, click on the windings of the implant, because we lose the buccal plate here completely. So why do we have these complications? Probably is that we always look, when we talk about augmentations, we always talk about the time point augmentation to implantation. And we know from our studies, I learned during my university career that we have about 30% resorption of augmented autologous bone. Exactly, it's about 21 to 25%, but it's between augmentation and implantation. We don't know how much bone we lose between implantation and second stage surgery, or later on, between 2 years after prosto. We have one study by Wittmark, and this is really, it's not 35% altogether a resorption between implant and augmentation. It's not just 10% more, it's 35% more resorption between implantation and second stage surgery. But we have to keep in mind that this was almost all cases were hip transplants. And in that area of transplantation, the dentist usually overextended the bone augmentation by 30% because they knew they would lose 30%. And the problem is, if you overextend, you lose more. So keep in the contours of the bone, of the biologic envelope, and then you don't lose that much bone. Nevertheless, we have about 30% resorption at least are full block transplantations. Full block, it's not Curie technique. So there was two work groups who said, okay, we have resorption of full blocks, so we have a good method of preventing resorption, of preventing the bone from being resorbed, which is DBBM particles combined with collagen membrane. And they did studies and said, what happens if we put a full autologous bone block and immediately put a membrane on it? And what they could show is that the resorption rate was indeed reduced to 5.5% or 7.2% in those studies, which is much lower than it was with full blocks without the membrane. So that would be perfect. But of course, as we often have, doing one thing better, we have a disadvantage coming with it. And in this case, we had two disadvantages. The DBBM particles were not integrated in the area of the bone, of the full bone block. As you can see in the pictures, it's the only pictures I show which is directly from that study. And you see that the DBBM particles are integrated where they're on the bone, on the local bone, and not integrated when they are on the bone block. And the second problem was that the dehiscence rates were higher in the groups with the membranes, which was 3 of 11 cases or 4 of 42 cases in those studies. So we have an advantage combined with some disadvantages. And then my friend Luca Di Stavola, who I made my education, my oral surgery education in Professor Curie's clinic with, had an idea. He said, okay, we can do the split bone technique, and the split bone technique is probably with lower resorption. So we don't have the problem of that much resorption. And afterwards, we can do the GBR procedure in a second step. And that's what we did here. We did the split bone technique first and did the second procedure, and we did a little study about it during the implantation. I show you a case of this study. It was just horizontal augmentation in that study. So the patient has a severe atrophy. We don't have enough bone width in that area. And so first of all, we harvested a retromolar bone block. And after that, we put the plates, 2 buccal plates, and filled the gaps in between with autologous bone chips. So we closed this again and waited 4 months. 4 months is always the healing time. In my cases, I always wait 4 months. And after opening up again, we see perfectly healed bone again. We see we could easily insert the implants. And as most of you will immediately say, there's enough bone on the buccal side. So the risk is low. But nevertheless, we put the GBR procedure on top now. Just one layer of DBBM particles and a collagen membrane. And we closed up again and let that heal again. And what we could find, it was a very small study we did here. What we could see is that we had just 5% resorption rate between augmentation and implantation due to the split bone technique. And we gained, of course, we did another augmentation procedure, and we gained another 17% compared to 100% at the end of the first augmentation during the GBR procedure. And at least in the radiographical pictures, we could estimate that these particles were perfectly integrated on the bone. So we don't have the problem that the DBBM particles are not integrated into the local bone. I show you a clinical picture at the end of this lecture where you can see how the good integration of the DBBM particles. So this is the case after we do a Casangian vestibuloplasty here for gaining keratinized, no, not keratinized, but fixed mucosa. You can perfectly see in the lower left picture, this worked very, very nice for gaining a fixed mucosa. It's not keratinized, but fixed. And this was the final result shortly after prostorage. And I have 3 years pictures of this case. And as you can see I had the possibility, because I made some implants in another place, and I did the Cbct scan of the right side as well. And you can see the perfectly integrated DBBM particles and the perfectly integrated bone in that patient. And that's what we found through this study. And we are currently working on a 3 to 5 year review of our patients. We recall them at the moment and try to see how they look like after 3 to 5 years, because we don't want to see the short-term results. We want to have the promising that we have good, longer results. This layer, we call it relining layer or relining technique, will not prevent peri-implantitis cases. That can prevent that. But the aim of this second augmentation step is to prevent the resorption that might happen 2 to 5 years after the augmentation procedure. And this is the first 20 patients we reviewed during this retrospective study we're doing at the moment. This is the case as a different implant system, but all have in common that we did the relining procedure here with autologous bone and in the split bone technique. And we had just one case. This is one patient with 2 X-rays here who lost bone during this 5-year procedure. And it sounds a bit like an excuse. We have just one case at the moment with losing bone, but this patient was a perio patient. I treated myself. I made the perio treatment myself. But he didn't show up at the referring dentist or in my office for 5 years for just one supportive periodontal therapy. So we can't prevent patients from losing bone if they don't come to the supportive periodontal therapy. We perfectly know this from current publications. But most other patients, and as you can see, some have, the prosto is not perfectly done, but we have almost no bone loss in these cases 3 to 5 years after insertion of the implant. So this is quite promising that the relining technique really will be a good thing in the long term as well. I made a long way now and taught you about relining different techniques, but you have to understand where I came from and why I go this way. And you will see with all my allogenic cases, you will see this relining technique. And I was asked very often, do you do the relining because of the allogenic bone plates? And I can clearly say no, I do the relining with every autologous bone plate as well. So that's why I did this big step before we now come to allogenic bone plates. The problem is bone harvesting is of course, something can be done. I would avoid the word easily done. But if you have some experience, you can do good bone harvesting. And it's not a big danger for the patient. But nevertheless, everyone should be a bit aware of what he's doing, because there is a nerve and you have to keep in mind that you don't damage the nerve. And there are two studies measuring the distance from the external cortical plate to the canal in the area of the bone harvesting. And in most of these, 99% of the patients, the bone in these studies has more than 3.2 millimeters thickness. Why is the 3.2 so important? Because the microsaw has an insertion depth of 3.2 millimeters. So that's why I looked for the 3.2 millimeters. Since I have my own CBCT scans here in my office, and I scan the Eastern Westphalia patients here in Germany, I have to admit that they don't have these big cortical distances in the area where we harvest the bone. Usually I see that they have 2.3 to 3.5 millimeters in distance. So things can happen quite often. You can see a bit of the nerve, as you see in the picture on the left side. That's not a big deal. You put a collagen sponge on there and it heals perfectly. Very seldom is a complication like the one on the right clinical picture where the complete infraalveolar nerve canal broke out with the block. I had that 3 times in my career so far, but this is really a nasty complication because it takes very long to separate the canal from the block to get it out. But what nobody talks about is what is about people coming back to our office, because I'm 14 years now in my office, and more and more patients are coming back for another implant. And in these patients, I have already harvested bone blocks. And the question is, do we really have a 100% regeneration of the area where we harvest the bone? And there was a nice systematic review by Anton Skulian showing that we have a good regeneration, especially the rebuilding of a cortical plate is usually quite good, but we have a loss of contour about 25% in 62% of the patients. And we have to see in this review, patients are also integrated into the review, which had where very little bone blocks have been harvested, where usually the contour is not completely damaged, so the soft tissues do not collapse into the defect. But if you do Curie techniques or make these big bone blocks I showed you, you will definitely have some collapsing of the soft tissue on the harvesting area, and then you don't get that much regeneration. Look at the 2 CBCT scans. This is the second bone harvest planning in my office, and you see one patient had about 1.4 millimeters of cortical bone thickness, and that's probably a very, very hopeful measuring by myself. And that's something on the right side I really saw just once, a patient where the cortical plate over the nerve canal did not completely resolve. So in these cases, it's very dangerous and very difficult to harvest bone. And I had a case like this. I had a patient, I already had put an implant in the maxilla, and I used a bone block for that. It's not the patient I'm showing you now, but it's quite similar. I didn't document the patient so well, so I used this to show you the steps. And the company that provides the allogenic bone plates gave me the bone plates and say, try it. And probably most dentists in our office are not that keen on trying something with their patient, because the patient expects us to do things that are really good and scientifically based. And the plates probably stored into my cupboard for about 1.5 years. And then came a patient. I had to do 2 big vertical defects, like in this patient, and I could not harvest enough autologous bone. And then I said, okay, now I'm going to try these allogenic bone plates. And I show you how we did this in this case. So On the left side, in this case, I harvested the autologous bone, and I made the 3D augmentation with the autologous bone. Again, as I told you, buccal plate, oral plate, 2 screws on the buccal plate, and fixing the oral plate through the buccal plate with 2 more screws. And we put autologous bone chips in between and closed this side. On the right side, I used the allogenic bone plate. Same method of fixation, but I filled up the gaps completely with autologous bone chips, not with allogenic bone chips. That's an important thing. Autologous bone chips. And then we let both sides heal for about a month. This is the panoramic X-ray directly after the and this is the autologous bone side, and you see quite good healing. We have a nice, very nice bone. We have enough width, we have enough height, and the same thing on the other side. Yeah, we have enough width in our side, and this is the clinical pictures here. And you can see both sides. We have a very good, and we could easily insert the implants, and then we do the relining techniques on both sides, on the autologous side as well as on the allogenic side. We let that here for another 4 months. Yeah, this is the panoramic X-ray after the insertion. And then, as I showed you in the last case, we do a Casanger vestibuloplasty for regaining fixed tissues on both sides and let this heal, and then the prosto is done. This is directly after the second stage surgery, and you can see the relining layer is perfectly incorporated into the local bone. And this is after 2 months after the prosto surgery. So this was very promising to me, because I saw there was another method of using the shell technique, the split bone technique, but I didn't have to harvest that much bone. So that was quite good. There are cases where we cannot harvest, or there are probably several dentists out there who don't want to harvest with a microsaw or with a piezo surgery. We just need to harvest in that case with a sail scraper some autologous bone chips. And I show you, so far we've 12 cases with picture documentation, and we have done about 20 to 25 cases where we did one side with autologous bone and another side with genetic bone. And this is patient number 1, by the way. This was my first patient. And you see we have quite a good healing, similar resorption patterns on both sides. So very nice healing on the allogenic side, which is on top, and on the lower pictures we have the autologous bone side. This is another case. I show you 5 of the 12 cases I've documented, and you see perfectly healing on both sides. We see slight differences between this. We have to say that. The autologous side shows a little more resorption usually, but the better integration of the plates. And the allogenic side shows less resorption, but less integration of the plates. But with the relining technique, it was so far never a problem with the integration of the allogenic plates later on, that they came out later in that area. This is another case with a big augmentation procedure. On the left side, we have, in the lower picture line, we have the allogenic bone plates. On the upper picture line, again, the autologous bone plates. And again, we see perfect healing on both sides, and we did the relining on both sides again. And this is a case I'm going to show you, and again, we see similar results on both sides. So we have now accepted publication in clinical case reports about the first 5 patients we did in split mouth design. It was not a study. We did really for medical reasons, the split mouth design, because we couldn't harvest enough bone from one side for both areas to be augmented. And this is a very complicated table here with many numbers, but let me explain some of the numbers. We have divided between horizontal and vertical bone augmentation, and usually you see in the studies the number of maximum augmentation, so the area where the bone is the thinnest or the biggest vertical defect. So you can have a look at the line maximum augmentation. And in the autologous bone side, for example, horizontal, we had an average width of the crest of 2.8 millimeters and augmented 7.3 millimeters horizontal augmentation. And we lost 0.4 millimeters between augmentation and implantation and regained another, I have to remove this little thing so I can see all this better, regained 0.5 millimeters after relining. And we have quite similar numbers with the allogenic bone plates. You see we have a little less resorption with 0.2 millimeters and regain 0.7 millimeters after relining. And the same thing for the vertical plates. Maximum augmentation side was 5.5 millimeter vertical defect, and we rebuilt the complete defect during the augmentation procedures. We lost 0.5 millimeter, which is about the 10% I told you, and regained 0.3 through the relining technique. And we have quite similar numbers with the allogenic bone plates. So we can perfectly see here that we have similar results, and that was quite promising to me. And that's why I changed the way I explain the techniques to the patients, because there are patients who don't want to get bone harvesting in their mouth. And I have for this patient now an opportunity how to rebuild their bone. And there are other patients who don't want to get allogenic bone, just for religious reasons, for personal reasons, and they say, don't give me bone of another person. I understand that completely, yeah? And I can do the autologous bone plates with these patients. And considering now the possibilities, I show you my last case again, which was the case which finally made me believe that this really is a very, very nice technique. It was a patient with several congenital missing teeth. And I told the patient, okay, we harvest bone in the retromolar area, and when we don't have enough bone, we combine this with allogenic bone plates. So we use both sides. Then I made the Cbct scan, and this was a Cbct scan of the retromolar left area, and the right side didn't look better. So I knew I could not harvest a bone block here. You will see later on in the panoramic X-ray, I tried anyway, but I realized during trying that it was not possible to get any bone plate in the autologous area. So I just used a safe scraper here to get some bone chips, and I told the patient after the CBCT, okay, we do all the augmentations with the allogenic bone plates. But look at the areas where we tried to augment the bone, or where we wanted to augment the bone. It's really thin. This patient really has thin bone areas where we wanted to insert the implants. This is all the 8 positions where we wanted to insert the implants. But what was the alternative now? The only alternative would be to use a hip transplant. And I wanted to avoid that. I don't do hip transplant myself, I have to admit, but so we used the allogenic bone plates. Here are the sites in the mandible, yeah, with the allogenic plates. As you can see, technique similar to that we already saw with the autologous bone. We use a buccal plate, an oral plate, and in these plates I put autologous bone chips. This is the areas in the maxilla where we took the allogenic plates with autologous bone chips, and only in the area of the first premolar on the left side in the maxilla, we put an implant directly and did a GBR procedure with it. So this was the area right after the augmentation. You see the trial of the bone harvesting. Yeah, on the left side, which I didn't finish because I realized during drilling that this wouldn't be a very good idea. And this is the 4-month result. And it really looks perfect. We have really very nice bone now. And it was not my first case with several congenital missing teeth. I did some cases with autologous bone before. And these patients usually have quite high resorption rates. Yes, the bone is usually resorbed, and always have to do a GBR procedure on top. I did before we started with the relining. And using the allogenic bone plates, which show lesser resorption rates than the autologous bone plates, we have quite stable bone during the 4-month of healing. This is in the upper jaw, and again you see that the plates are less well integrated with the allogenic plates than the autologous usually were, but quite good stability of the bone, of the augmented bone, and relining procedure again. So this was after the implant insertion, and we waited another 4 months here. And this is second stage again, and that's what I promised you to show you, because it's one of the cases where I opened up a little more to see how the complete thing healed. And you see in the lower picture in the middle, the good integration of the DBBM particles on the bone that was built up before we put the GBR. And I really have to say, the GBR procedure, that was quite surprising to me, works, in my opinion, a bit better after the shell technique augmentation than if you put the DBBM particles right on local bone. I don't know why, probably because the area of augmentation is already in a healing phase, which makes the integration of the particles faster. But this is what we quite often see, very, very nice integration of this relining layer on top of the implant. So again, soft tissue management at all other places where we put the implants. And this is the patient after the prosto procedure. And what would be the alternative for this patient? The alternative would have been hip transplant, a very, very invasive procedure, in my opinion. And I think if we can do a really difficult like this with the allogenic bone plates, then we really can say this works. And so we have an alternative now. We can do the shell technique with autologous bone plates, we do with allogenic bone plates, and that's really the way we do it in our office now. The patient can decide which way of augmentation he prefers, and that's what we do there. So I'm ready with my little lecture. This is my platform. Omid already mentioned the regenerative biodiversity on Facebook and Instagram. I really invite you to follow us, share your own cases. It's an open platform where everyone can share his cases. And hopefully we see you there. And there we always post very, very good. We like to post cases, usually done, shortly done. We can discuss about the criticism. Everything is allowed on this platform. Thank you.
So much, and actually, as I said, it was and it is a very, very interesting topic, and I'm really ready for our hot discussion on the hot seat, because I have to say now, I'm really great fan of allogenic bones, and you know, we have a company also in Iran that they produce allogenic grafts, and they have history like 15 years, and the interesting thing is that after doing many years of Huri technique, about 2 years ago, I asked them to produce bone plates with the mineralized quartz, and they did it, and we started to use it, and I actually have some questions for you. And it was really interesting for me when I saw you post cases on Huri technique and horizontal vertical augmentation plates. And that's why that I want to know your idea about it. I don't know, we have some noise, I think. Do you hear me well?
It was not that well, but it was okay.
Okay.
I could hear you.
Yeah. You know,
a little gap.
Yeah, it's okay. Speaking of allogenic plates, so as I got the points from your presentation, your success rate was equal, right?
Yes, right.
So you had equal success rate with autogenic bone and allogenic bone. So now my question is this. When you open the flap in the second stage for implant placement, do you find the outline of the allogenic plates, you know, I think I better ask my question this way. Usually when we open up the flap, when we've used allogenic plates, we can easily demonstrate the contour of the plate. But when we reopen the autogenous bone, it's completely integrated and it's exactly like patient's own bone. As I noticed in your cases, in some of the cases, we couldn't really say where is the allogenic plate. But in some cases, it was exactly there, so we saw it. But in both cases, you waited for 4 to 5 months, for example. So what is the difference that sometimes we see the outline exactly and we think that maybe even it's necrotic or something, but sometimes we cannot differentiate the outline. What do you think about it?
Yes, that's a very good question, because I have to admit, in these pictures, you saw 3 generations of from the same company, nevertheless. The first plates I used were, it's all FDBA plates, but some were gamma sterilized later and some were not. The plates that were not gamma sterilized usually integrate a bit better than that one that are sterilized. But the company only provides plates that are sterilized anymore. So these integrates take longer. The integration probably takes longer. Nevertheless, we did really some, with a tree fine burr, we took some cylinders, and there's no soft tissue between the plates and the autologous bone chips area. So the integration is good. But you are absolutely right. Autologous bone integrate a bit better. That's what I see too. Nevertheless, we have a 3rd generation plate at the moment, which is very thick. It was 1.1 millimeter now, and they made the plate thicker because some dentists had problems breaking during the process of fixation. And I'm not so happy, so it's going to be a thinner plate again by the company. We're working on that at the moment. But the big plate, of course, is even worse integrated than the smaller plates because it takes more time to integrate in a slower resorption process. I usually, when I open up, I have the same picture as you described. You see perfectly the allogenic plate, and I go with a burr and reduce the thickness in that moment. And when I come to the inner layers of the plate, it's better and better integrated on the bone. So some pictures of that you saw here, the layers were already with a burr reduced, and so it's quite good integrated. We do the plates now for I think 4 years, and so far, using these techniques with relining, I didn't have a late exfoliation of the plate. That it came out at some patient. That was something I asked myself, will I have a late loss of this plate? And I already saw it with autologous bone too, that the bone plate comes out after 2 years. So far, I did not have this with using these steps. I did some tries with immediate implantation and plates, and they had one patient where the plate came out after 1 year. So, but in this case, I didn't do the relining technique. So taken together, we can say the integration is worse and the stability is better than autologous bone.
Yeah, and you talked about the thickness of the plate. So usually, as I know, the thickness that usually everyone prefers is about 1 millimeters, right?
Usually, most plates are they're different sizes. We have the first plate we used was 1 millimeter in thickness, but could be thinned with a safe scraper. The gamma sterilized plates cannot be easily thinned by a safe scraper because they're going to break then, because they're less stable for that. So we have 0.8 millimeters to 1.1 of the plates.
To 1.1. Yeah, that's a great point because really I didn't know about it. That sterilized plates actually shows different behavior comparing to those that have not been going through the sterilization in that process. And I think another good point that you mentioned, that it's crucial to put autogenous particles between the allogenic plate and the patient's bone, because it really shows difference in the results that we're going to gain. Now, my next question is about smokers. In smokers, do you prefer to use allogenic plates or not?
I can't say for sure because we are currently going step by step further with the smokers. At the beginning, when I started, I didn't make the plates with smokers because the point was the worse integration of the plate, and usually we see this with autologous plates as well, that the plates are less well integrated in smokers. So I was a bit careful. At the moment, I use the allogenic plates with smokers less than 15 cigarettes per day. And I want to do the next steps and do with heavy smokers with more than 20 cigarettes a day. But I can at least say less than 15 cigarettes is working.
Is working. And yeah. Yeah, but you know, one of the other things that I want to ask you is that speaking of flap design using the plates, I noticed that in many of your cases, you put the incision line immediately close to the area of the augmentation. I really didn't notice that to go like 1 tooth or 2 teeth further the area of the augmentation. Do you think the placement of the vertical incision have an influence on the exposure of the plate or the augmentation site in the future or not?
Yeah, that's a very good question, because we can have a long discussion where to put the right relieving incision. Usually when I do a big augmentation, and when we use the plates, we have a big augmentation. I do releasing incision coming out from the sulcus of the neighboring tooth and going not straight downwards, but with a little diagonal line. Because when we do go 2 teeth further from the area of augmentation, we have to do a split flap for closing the wound again, and we have to move the flap quite away. And this usually comes to that we lose the keratinized tissue around the neighboring teeth if we go 2 teeth further. So I avoid this during big augmentations, and I do this when I do just small augmentations. And doing the relieving incisions not in a straight down way, which would be better for scar tissue formation, but in a slight diagonal way, is easier for closing then.
So, you know, because I noticed the case that you showed using the non-resorbable reinforced membrane in the posterior part of the maxilla, and you showed the exposure. So also in that case, the releasing was exactly close to the area of the augmentation. The reason that I asked the question is that maybe depend on the technique for augmentation procedures, the placement of the vertical incision should be different, because, for example, non-resorbable membranes, maybe it put more susceptibility to the exposure or bacterial contamination to the membrane and increase the risk of exposure. But maybe plates, the scenario is different, and we can even put the incision close to the area. And you know, about putting the plate on the patient's own bone and fixing it. Because in your cases, I noticed that you place so many screws in the plate. And it's really interesting for me, because do you think that putting the screws may increase the risk of plate fracture or not? Because, you know, for example, in an area, I saw maybe 4 screws going into the plate. And my other question is that, do you put the screws at the time of fixation, or you drill the plate outside the mouth and then fix into the area?
Yeah. right. Every screw, especially with the allogenic plates, because they tend to break easier than the autologous plate, every screw is a risk of breaking. So the most important thing is to take the right screw. You have the screw that is straight and not going to diverge at the end, because the divergation at the end will put some pressure into the hole, and the plate might break then. So it's very important to use a small screw. I use this 1 millimeter screws, and these screws are straight. So the risk of breaking through the screws is very low. But of course, it takes some time. I do this for, let me say, 16 years now, and I have some experience with it. And I already broke an allogenic plate too. It happened to me as well. You can put 4 screws, it's no problem, but you have to be, of course, be careful. And I always drill and put the screws inside the mouth. Because if you do it outside, it will not be the perfect position, and you will always slightly shift the plate inside the mouth, position you'd like to have, or where you prefer to be the plate to be. So inside is much better. It's difficult, probably what you mentioned or what you meant is the oral plates putting inside the mouth. That's probably the most difficult steps when you do the technique like I showed it. There are special bone fixing instruments that you can hold the bone with. We're currently working on a new, which is a little thinner, so easier to handle. But this is the most difficult step usually.
Yeah, yeah. And you know, my final question is that about the screws. Do you prefer the self-threaded screws or the blunt screws for fixing your plates?
I couldn't understand the kind of screws you meant.
You know, some screws have very sharp threads. So when you screw it to the bone, they engage to the plate. But some screws have blunt threads, so they don't really engage. They just go through the hole.
Okay, yeah, now I understood. Yes, it's fixation screws for 2 reasons. Because usually you do the screw fixation where you want to fix a position of the plate, and so you have to use a screw that won't compress the plate to the bone. You could use a hole which the screw goes through when you do the second plate, but especially with the allogenic plates, you will have very high pressure on the plate then, and this might easily lead to fracture of the plate.
I got the point. Got the point. Well, Jochen, I have to tell you, your topic is very interesting, and I think if we sit here, we can talk about it for hours, but I know your time is limited, and really I want to thank you for your precious time and for your beautiful presentation and that you shared with us from this platform with all the dentists from around the world. So thank you again, my friend, and it means a lot. And I have to say again, I'm truly a great fan of your work. Keep it up, and pretty sure we will see so many more cases of you in the near future. Really looking forward to see you very soon in person, and thumbs up and God bless you. Thank you.
I thank you. It was really a pleasure. Very, very much pleasure for me.
Thank you so much, my friend. Stay safe and hope to see you very soon.
Yeah, so do I. Goodbye.
Thank you. Thank you.